Good morning. This is the introduction lecture to DEN 7354, Special Patients. Today's purpose in terms of the lecture is to introduce the course. We're going to talk about the goals that we have for this course, the assignments, the class sequence, and case presentation example. So the goals within this class are for you to have an understanding of the comprehension of special patients by definition, an evaluation of special patients, and the collection of a complex medical history, the ability to collaborate with a healthcare team and provide the stakeholders who are involved in the care of a special patient with the information they need to make proper decisions, to synthesize all of the components required to understanding a range of disabilities which may affect your patient population. When we're going to teach you how to construct a schema for medicine and drug interactions, which are of significance to dentistry, as this will directly impact the choices that you make in terms of your treatment and in terms of the progression of the appointment. And then understanding the therapeutic management of common oral lesions. Again, you've already covered multiple oral lesions in several different classes. Now we're going to start piecing that together with the proper treatment choices, especially as it applies to a variety of different patients. In addition to that, we're going to understand the barriers of healthcare. When I say barriers of healthcare, I'm talking about things that keep you from treating certain populations and things that keep populations of patients away from the dentist. Things that government does to either help or hinder the care of those that are disadvantaged or disenfranchised. We're going to talk about the categorization of those barriers, and then we're going to talk about some of the possible solutions for those barriers. We're going to identify behavioral disabilities. We're going to identify and understand intellectual disorders. We're going to evaluate standard psychiatric disorders. Then what we're going to do is spend the next several lectures deep diving into immunocompromised patients by system. When I say by system, what I'm talking about is we're going to cover issues surrounding lung problems, issues surrounding heart problems, issues surrounding the blood flow or quality of the cells. We're going to talk about pregnancy. We're going to talk about multi-pharmacy. Basically, we're going to attack various areas so that you have a better understanding of what compromises you may have to make based on the overall systemic challenges that your patient has. Then we're going to go over models, issues, and needs that concern patients with cardiovascular issues, pulmonary issues, gastrointestinal issues, genitourinary issues, endocrine and metabolic issues, pregnancies, allergies, oral and general cancers, and physical disabilities. Again, this is kind of an introduction to all of these issues, but more and more of your patients are going to have one or more systemic compromises, which you're going to have to address in your treatment planning. We're also going to have an introductory lecture on the guidelines and expectation for IV and IV general anesthesia treatment in dentistry. We're going to talk about the process involved in an IV or IV general treatment plan. We're going to talk about the forms, the consents, and the basic complications. We're also going to cover local anesthesia and interactions specifically with special patient medications and or IV and GA medications. You may or may not have noticed that there are several handouts which have been published. I strongly suggest that you know each and every one of those handouts. They come predominantly from the book, and they are essential to understanding both treatment planning and problem solving when it comes to complex patients, and it is absolutely fair game for test, and it is definitely on your boards. So one of the goals that I have for you is for you to be able to understand and manage these patients and understand how you need to modify your treatment plan individually, patient by patient. I also want to set you up in a very repeatable routine for how you examine a patient. And when I say that, what I'm talking about is really when you look at your patient for the first time, you want to look at them whole body. You want to gauge their gait, their speech, the overall cleanliness that they're presenting with, the engagement that you see within their eyes, their personality, their goals, their limitations or fears. Then I want you to move in from that point towards looking at the overall outside structures of the head and neck, whether the eyes are even, whether the nostrils are open, flared, congested, quality of and positioning of the zygoma, of the ear, of the chin, of the lips, of the philtrum. Then moving into soft tissue and how the quality of the soft tissue looks, then working your way into a cancer exam, checking underneath and around the tongue, checking the back of the throat, the cheeks, and then finally moving to hard tissue and utilizing your x-rays to go in between the teeth and overall down below. And basically be able to repeat that every single time so that your chances for missing something go way down. It also kind of helps you to organize how you're going to approach this particular patient in terms of designing their overall plan, in terms of designing their individual appointments, and in terms of keeping them as a lifelong patient in your practice. This kind of repeatable, redundant type of exam process works very well to eliminate errors and to keep a very consistent high level of care overall for your patients. Okay, we're going to look specifically at several different complex cases. Again, if you've had a chance to look ahead at your syllabus or at some of the modules that are available, you each will be participating in one of 12 groups, which is specifically going to be going through a complex medical issue and a variety of different dental problems and creating that comprehensive plan. Also, we're going to teach each other about a variety of different medical issues that come up in our daily practice so that when you have your diabetic patient or your hypertensive patient or your patient on a variety of different beta blockers for heart conditions or your COPD patient, you know kind of what you should be looking for, what are red flags as you're planning the treatment. We're going to look at specific tips and techniques that manage special patients. This is kind of how you get them through a variety of different treatments. And what I'm hoping is that you'll see that there's a very distinct relationship between how we choose to manage a special patient and how we choose to manage our regular patients. For example, if you would pad out a chair with, say, neck support or elbow support or knee support for an elderly patient, you might do the exact same thing for a 30-year-old because, again, they're going to be more comfortable, more at ease. If you provide earphones or video for them to view or some other form of distraction, again, you're providing that, say, for your Down syndrome 40-year-old, you might find that that works very well for your regular 40-year-old as well. So hopefully the tips and techniques that we bring to special patients will apply to all patients. And then we're going to go over complex case algorithms again for diagnostics and treatment planning. There's enormous amounts of information that as oral physicians we need to have control over and understanding of in order to correctly manage this patient. One of the things that can be very frustrating as a dentist is that for some bizarre reason, because we don't go to med school, we go to dental school, there is a bias both on the part of the patient and on the part of the primary care providers to provide us with equal time for our patient and equal understanding of their overall global issues. So you really need to come at this from a physician's point of view, not from a technician's point of view, and seek to present your case concerning your mutual patient in a way that your medical doctors and or your stakeholders understand and respond to. Wasn't that long ago that we had a patient in the chair who was positive for HIV and for whatever reason hadn't disclosed that. As we sat and talked with the patient, eventually they did volunteer that they were HIV positive and that they were on a couple of different medications, and then volunteered that they didn't think that dentists needed to know that because they were just teeth. So again, we have to surmount or overcome this natural bias that kind of exists in our society against treating dentists as part of the body and also as a full-blown legitimate physician. Part of our responsibility is that we come to the table with proper education, proper vocabulary, and proper understanding of these patients so that to a certain extent we validate our claim that we are oral physicians and an integral part of the overall healthcare team for the patient. Okay, so let's get down to the nitty-gritty, kind of how we are going to be grading this class. 25% of your grade is represented by a group project and group presentation. When I say group project and group presentation, I know that you're all quietly, or perhaps not so quietly, moaning and groaning because group presentations and projects have a great deal of negative connotation around them. However, there is no way to practice special patient dentistry without a group. You're going to have a variety of different caretakers, a variety of different physicians, a variety of different therapists, your own team, and yourself that all have to be coordinated. So the exercise here is to learn how to coordinate a big group. However, each and every group project element has individual elements, and everyone is responsible for at least one of those elements. And when we do our group presentation, everybody needs to actually talk. So there isn't one person writing a paper, one person presenting a mini lecture. It's all people in that group. Your grade is going to be a combination of collaboration, i.e. I'm going to be tracking your Discord, seeing where you're communicating, where you're meeting, how you divide your assignments, whether or not you're participating in polishing each other's elements of the presentation. And it will ultimately not be completely due to your collaboration, but also to your individual effort. So anybody who's skating on the other people, that should be reflected in their grade. We have a midterm. It is the first half of the course and it's worth 30%. We have a final. It is worth 35%. I do not make my examinations cumulative as a rule. However, if the class misses a large section of information on the midterm, that will reappear on your final. And then we have a paper this year. It's worth 10% of your grade. If you look at the rubric and description of this paper, it is not a long paper. I believe it's roughly 500 words, and I will not ding anybody if they go up to 750. However, if you go over 750, I will not read the paper and I will give you a 0 for that. So I do need you to keep within the 500 to 750 word limit. As far as it goes, you will be able to select a syndrome if that's what you wish, or you will be able to select an emergency scenario if that's what you wish, and you will need to meet the requirements of the paper in order to get full credit. There are 2 areas in which I will ding you, and as far as that goes, it's 5% for each unexcused absence and 10% for each unprofessional behavior action. You do need to pass this course. It is a 2-unit course. I personally do not take roll, do not require you to sit at a specific place, and do trust you to be an adult. However, you do need to be present for the lecture in order to understand the basic requirements of the information. So if you're consistently not there, and or if you are consistently behaving in a way that is not professional, that will be reflected on your grade. hopefully with any luck, this will not be a big issue. Again, I am not your babysitter, so if you need to get up to go to the restroom, or you need to leave a few minutes early because you need to set up for a patient, or you need to show up a few minutes late because you had a personal crisis, I am not going to really note that at all. However, if you are busy going internet shopping or surfing the net, or in some way not exactly paying attention, I do guarantee that as a pediatric dentist, I am incredibly creative for public embarrassment and have absolutely no qualms coming and climbing in next to you and your seat, or dragging you up to the front, or in some way sharing with you the fact that I think that you're a little distracted. Um, Probably you remember this from previous lectures with me, but if you don't, we have all summer long for you to get to know that pediatric dental personality. Okay, so again, just to go over the midterm and the final. The midterm will cover the first half of the course only. The final will cover the second half of the course. However, it will have cumulative questions based on class performance in the midterm. Absent students will always have cumulative secondary exams. Okay, so I am not going to argue with you if you have a family emergency and cannot be present for the midterm or final. However, you will not be taking the same examination as your colleagues. You will be taking a cumulative examination, and it is specifically written for you. So do keep in mind that if you make me write a second, third, or fourth test, it is likely to be more difficult. Okay, let's get into the group assignment and group presentation responsibility. The group presentation will consist of several points. Each point will be given to a specific student within your group. So one of you will take the general health of the patient. When I say the general health, you are being given a specific disease or disorder, a specific medications that they're taking. You then create a patient who meets that profile. So if you have a juvenile diabetic, they might be a 26-year-old patient. If you have a COPD patient, they might be 65. You get to design if they're male or female. You get to design if they are 20, 30, 50, 80. You get to decide if they are an incredibly wealthy rock star or a indigent, derelict personality. That part is both creative and within the limit. You're going to get a list of medications. Someone needs to tackle what class those medications are, the uses of those medications, the contraindications of those medications, and the interactions of those medications. If you go back to your handout, you will find one of the handouts specifically allows you the process of how to classify a medication, use that medication, indicate the contraindications, indicate the interactions. I am especially interested in interactions that would affect the dental environment. The next thing that goes on is going to be consents required. So depending on what this medical history is, there's going to be different players involved in this case. For example, if you have a patient with cancer, you're going to have an oncologist, you're probably going to have a hematologist, you're going to have a primary care physician, you're going to have a therapeutic element, like physical therapy perhaps, or speech therapy. You're going to have maybe caretakers involved in this. If that patient is no longer able to support themselves, they may be in some kind of home, there may be nursing staff assigned to them. You need to understand who has the right to consent to treatment and who needs to be involved in home care or overall maintenance. The next person in the line is going to work very closely with consents because they're going to create a stakeholder map. This stakeholder map shows you the intimate elements required for care. For example, this might be the person that's going to drive them, the person that's going to pick up their medications, the person that's going to have the consent, the person that's going to accompany them to appointments, the primary care physician. And then a layer out might be the therapeutic people, the specialists involved in medical care, the government support team that they might have. on and on out in concentric rings, telling us the importance of the various people participating in this patient's care. Somebody is going to tackle the treatment plan based on the x-ray or the x-ray and photos of your particular patient. Someone else is going to handle the issues, how you're going to book this particular patient, how you're going to progress, what the home care process is, what the how you're going to sequence treatment. And then finally, all of you should participate in an infographic that covers the specific special need in a general way of this patient. So the other 6 points are individual to this patient. The infographic is a generalized information about the condition. Okay, this is important because if you just re-spit up the summary of the individual patient, you're not achieving this element and you will get zeroed out on it. The infographic is guaranteed to be a source where I find questions for the final. I will be utilizing each of your 12 infographics to generate at least 50% of the final. Okay, so what is an infographic? It's basically a visual that allows you to track a situation. I anticipate that this will be a colorful, engaging, summarizing thing, which covers the disorder, the symptoms, the diagnostic algorithms and or tests that you would order, the treatments, and something about the population that's affected by this. If you need examples from previous classes, please let me know, as I have several of those infographics that others have done, and you do not have to reinvent the wheel, but you do have to create your own unique infographic. I do not care what system you utilize to generate your infographic. Whatever computer system appeals to you, frankly, you all are a lot younger than I am, and your skills with computers are just head and shoulders above my skills. So I completely support you utilizing whatever program is effective. Do remember, in the case of this group project, you need to turn in a paper as well as generate a PowerPoint or Google slide presentation. That paper also needs to include the infographic, okay? When I say paper, I do not necessarily mean that this has to be a book written of flowing paragraphs from section to section. What I do mean is that each of the 7 points that are covered need to be in a form that I can read, and you need to have 3 sources for your information. Please do not give me Wikipedia sources. Those are not considered scholarly and they will not be acceptable. You must submit your paper before you give your presentation. When I say you must submit it before, it can literally be the night before. I do not care about that, but do not hand it to me or send it to me post your presentation. Okay, so each group in this assignment has been randomized by the computer. It is a group of your fellow students, but it is not necessarily your best friends. Again, this is an exercise in learning how to collaborate with a different group of people. I do need for you to create a group chat, and I need for you to invite me to that group chat. You can use the Discord. That seems to be one of the most effective ways to create a group. I need to know who the point person is within your group, who's going to basically be responsible for making sure that the paper gets into my hands, that the presentation is done on time, and that you guys are filling out the Discord so that I can track you. I am interested in seeing that you guys divide the work equally and have discussions amongst yourselves about each other's parts, okay? And I will be looking at that. So don't be that group that ends up deciding at the 11th hour that now you guys are going to work on it, because I will see that in your Discord and I will grade you accordingly. I need a clear map of the project That can be an outline form at the top of your Discord, basically showing me who took what assignments, who took what steps, and what your strategy is to complete this assignment. Again, just bullet points are fine because I got to look at 12 of these. There should be multiple posts on your Discord. By that, I mean, I should see a post over the next week or two, basically saying, hey, we're a group. Who do we want to elect for point person? Okay, who wants to take which section? Okay, who's going to grab a couple articles? Are we going to load those articles up or create a bibliography here? Then maybe a couple of weeks later, it's like, okay, here's my section. What do you guys think? And then maybe a couple of weeks later, okay, let's get together, get the bullet point paper and the presentation worked up so that we're ready to go. But basically, if I see one post that says we're all in a group, and then one post that says, okay, we need to get this done tonight because it's due tomorrow, obviously I'm gonna look at that more negatively than I would somebody that's, you know, put in a little verbiage on the first week or two, a little bit more on the week 3, 4, a little bit more on 5, 6. Again, just to be clear, we need 3 sources on this. That needs to be a resource list or a bibliography. They need to be scholarly sources. They do not need to be books. They can be articles, and those articles can come from the internet. I am looking for a coordinated effort. Everybody should be participating in the presentation. Everybody should be participating in the infographic. Everybody should have a section that they're presenting. If you do not demonstrate those states, again, your grade will be affected. Every year, somebody or some group says, you know, we want so-and-so to present for us because they're the best talkers. This does not matter to me. If I see a single presenter, the whole group will suffer accordingly. Everybody needs to talk because you all need to be able to talk to your patients, to stakeholders, to other physicians. So no single presenter, no single person writing this project. Again, cannot say it enough, collaboration is key here. If you are not collaborating with the group, you are not showing capability to function in a complex patient care situation, and that is the exercise and goal of this class. Okay. As I said earlier, but I'm going to say it again, the final is drawn significantly from information covered by the group project. So your infographic, your quality of presentation is where I'm going to seek my questions. Again, if you are not covering this information effectively and I have to go research it on my own, those questions are likely to be harder than questions that I can draw directly from how you've presented the information. The project cannot be completed by a single participant, just as a special patient cannot be treated without collaboration. Failure to carry your portion of group work will result in the need to repeat the course, as this is a critical failure and there is no exception. So again, if I determine that as a group you did not function or I determine that you individually did not participate in your group, I will fail you in this section, and it is impossible for you to get an adequate grade because that is an absolute critical failure. So just like on your practicals, if you have a mid-range undercut on a crown prep or you have blown an ankle or something and it's an automatic F, it is an automatic F in this class. Okay. Cannot say it enough. We are healthcare providers. We are oral physicians. As such, we must coordinate teams successfully in order to complete their work. Okay. It is simply impossible for you to function as a professional physician without a team. Okay. So let's go in specifically to complex cases. When you are collecting information for a complex case, you need to take photos, you need to have x-rays, you may need a Panorex, you need to have a treatment plan, you need to identify the players involved in presenting that treatment plan and getting treatment plan acceptance. You need to understand the medications and/or medical situations that are facing your patient and how that's going to impact your treatment plan choices. And then you need to create your consents. You need to have a clear-cut plan and you need to assemble the correct tools, either to modify home care or to execute in-house treatment, or even to execute the referral of this patient to an area where they can get full general anesthesia or IV general anesthesia. Okay, so let's talk about an order of operations. As I was saying earlier, you need to have a methodical, repeatable process, an algorithm that you go through time and time again, because that's how you consistently gather the correct amount of information and don't miss something. First thing that we're going to do is get a medical and a dental history, and you're going to review that with the patient utilizing open-ended questions. You're then going to seek the proper consents that are going to be necessary for treatment. If you take a look at their medical and dental history and they are edentulous, obviously you do not need special consents for cleanings or for crowns or for fillings, but you might need implant consent, or you might need bone graft consent, or you might need denture consent. We need to address age issues. So if we are 95 years old and weigh 80 pounds and have polypharmacy, and we're really looking at end-of-life treatment and we're a very fragile patient, our choices for treatment planning might be strategically significantly different than what we would do in the same situation with a healthy 35-year-old patient with virtually no medical history. We need to have a review of social history. When I say this, what I'm interested in is a snapshot of where they live, where they work, who shares their home, who is involved in their personal care, so that I have a better picture of how to create a plan. For example, if you have a patient who sells blinds for less and they go on home consults every day, 5 days a week, from 7 in the morning to 7 or 8 at night, and they do all of their eating in the car. They don't have an opportunity to exercise, and they don't brush, and maybe they smoke to deal with stress. All of that is going to be relevant to designing the healthcare plan. We do need a diet history. If you find out that this patient is a bulimic and consistently bathes their teeth in stomach acid, you're going to have to design a plan to counteract that. And that's going to be critical. We need to have a feeling for what behavior modifications they're open to. When we talk about behavior modifications, we're not just talking about chairside behavior modifications. We're talking about lifestyle modifications. Are they willing to not drink 16 ounces of bourbon shortly before going to bed and forgetting to brush their teeth? Are they willing or unwilling to utilize floss or utilize a floss alternative? It can be very helpful to have a diet log or food journal so that we have a visual for when they snack, how they eat, what access to food and drink they have. Again, decay hinges on a pH of 5.5 or lower. So if the patient doesn't get into that 5.5 pH very often, the chances of them getting decay are lower. If, however, they're basically a grazer and they eat every hour on the hour, 12 or 14 hours a day, their chances for decay go up quite a bit. It sounds silly, but we need oral hygiene instruction. We need to understand, do they know how to manipulate a toothbrush? Are they capable of manipulating a toothbrush? Do we need to get in there and modify the handle? Can they utilize floss? Do we need to look at floss alternatives? Do we need to give them an artificial saliva because the medications that they are utilizing cause dry mouth? Again, oral hygiene instruction isn't just when and how, but also how we modify it as complications come up. We need to identify their chief complaint. Why are they here? Are they here for a cleaning? Are they here because their significant other threatened that they were never going to stay in the same room again if they didn't get their plaque peeled off? Are they in pain? Do they have a cracked tooth? Do they have trauma? What's the issue? And again, kind of tandem or side by side with that, we need to understand what the pain is and what it feels like. Then we apply our standard techniques for diagnosis. This is visual exam, a variety of different pulp exams, x-ray examination. Perhaps it's utilizing laser augmented diagnostics, but we need to decide what techniques we're going to apply. We need to review age, state of soft tissue, amount of root present for each tooth, your standard kind of perio exam. And again, this is where we collect data points, and data points help us to make our conclusions, which help us to design our plan. You can utilize that from photos, from x-rays, from measurements of growth and development, utilizing previous records, so pocket changes, decay that you're following that gets deeper. But you collect your data points every 6 months or every 3 months in order to design your plan. Then you're going to create a treatment plan that's ideal. Ideal means that money doesn't matter, time doesn't matter, state of the patient doesn't matter. This is the ideal treatment. Then you're going to apply the information you've already collected and design alternatives. These alternatives may address a monetary limitation, an age limitation, a health limitation, an intellectual capability limitation, a patient goal limitation. One of my most prized moments in dental school was I was desperate to get a set of full dentures, and I had a 62-year-old female present with only tooth number 9 in the front. And I got very, very excited because, haha, I was going to pull number 9 and get my full denture. She had literally come in for me to clean number 9. She wanted number 9 super shiny and clean because she played bridge every other week with her friends, and she wanted to be able to flash her one-tooth smile at them and chew her cucumber sandwiches. So I did not get to do the denture, but I did get to clean number 9 every other month without fail, in out-of-pocket charges for this woman. So sometimes your goals and the patient's goals are not exactly aligned. We now know, as we may not have known in the past, that decay itself is a progressive chronic disease, and we need to manage the disease process. This means utilizing things like getting a regular CAT score on the patient. We need to note the number of surfaces and line angles that are involved and have been compromised. All of these things help us to track the disease process. Are the pockets going up or down? Is the inflammation getting worse or lessened? We need to address tilting that caries continuum into the negative zone in a consistent fashion. We need to discuss treatment sequencing and follow-up with the patient with an eye towards common generic understanding. So on one hand, you need to be very medical and very jargon friendly with your colleagues, especially your medical colleagues. But when you go to talk to your patient, you need to utilize colloquialisms and a more generic conversation tone and vocabulary in order for them to understand your plan. No special patient should exit without a home care plan without modifications. It's simply not logical for you to put all of this time and effort into individual treatment appointments if you haven't created a way for them to maintain. And then finally, it is your job as the team leader to empower all of the stakeholders, to allow the caretakers to feel like they're participating in this process, and to allow the patient to feel that there's multiple sources for them to get support and understanding. When we're collecting this information, the key points that should stand out in the back of your mind are things like, is this treatment static or dynamic? Are we going with a definitive removable prosthesis because the patient is a dentalist? Or are we taking out class 2s as they come, recognizing that at this point we don't have the caries continuum controlled and that the dynamics of decay are constant? What is the significance of our extraoral exam and evaluation? How is their face looking? Do they have Bell's palsy? Do they have trigeminal palsies? How are we addressing the extraoral information? What extent of treatment is required? Again, this is something that tends to go up as the patient ages and or has more medical complications. What is the degree of difficulty required? So if we have a wheelchair-bound, respirator-driven patient, is this difficulty that we can manage chairside in our regular office, or do we need to refer to some kind of specialist? How can we address the behavioral needs of the patient? If this patient doesn't really wake up before 10 in the morning, setting them up for a 6 a.m. sedation may not be setting them up to succeed. What are the concerns that you have as the dentist? So if you're not doing all on fours and the patient really would benefit from an all on four, you need to be able to say, okay, this goes beyond my skill set. If the patient has active disease process going on or had a heart attack within the last 6 to 8 weeks, again, as the dentist, you need to see this is an area where my limitations are going to affect my treatment plan. And then what do you perceive as the greatest challenge to treating this particular individual? Is this a challenge that you can mitigate? Is this a challenge you can get further education for? Is this a challenge you can consult with an expert so that you're better prepared to deal? Or is this a challenge that really goes over your head or your scheme of practice pattern? And then finally, what does the patient want? So if a patient has gotten into the car and driven 2 hours to go to you as the dentist, their expectation is that you are going to be treating them. If you cannot meet that patient's need, it's important for you to say that very much upfront and very clearly so that they can weigh that into their choices. Okay, so here's a standard rubric for case presentation. When I say a standard rubric, what I'm talking about is this is something that a dental student might fill out and then present to their attending, okay? And then the attending might grade what they basically are presenting. Did they come with the chief complaint? Did they come with an updated medical history that they were able to articulate? Did they come with an updated dental history that they were able to articulate? Did they order the correct radiographs? Is the quality of the radiographs adequate for us to do diagnostics? And did they diagnose correctly? Did they understand what was required to make proper pulpal therapy decisions or proper space maintenance decisions? And then how aware were they of their elements and their diagnostics? By the end of dental school, you should be a safe beginner, knowing the bits and pieces that you need to create a comprehensive plan and being able to mentally present this to yourself and then verbally present it to the patient. Again, if you look at this rubric, you're going to understand why I'm recommending a very ritualized, repeatable algorithm for you to follow, because all of this information should be collected in a very timely fashion during your new patient exam or during your recare exam. Okay, so let's go through a complex case and see kind of how I would collect this information and data and then create a treatment plan. So we're going to look at a 7-year-old Hispanic male. If you take a look, we've taken what I like to call the pediatric full mouth series. This should give you the anteriors kind of as a group with an idea of whether these succedaneous teeth are present, as well as open contacts for the molar teeth. Ideally, you should be able to visualize the distal end of the bicuspid and the distal end of the farthest back molar. So hopefully with each of these pictures, we have an adequate information. If you study these pictures, your colleagues did not get adequate information for the right-hand side, i.e. you cannot see the back side of the canines. The next bit of information collected was a pantograph x-ray. This does give you sort of an overall picture of the health of the sinus, the development level of the spinal cord, the position and presentation of the TMJ, the quality and number of teeth that should be present, and whether or not there's any radiographic pathology that can be noted. We supplemented this with photographs. This gives you a better idea of what's going on kind of in this patient's mouth. If you take a second to look down on the lower left-hand side, you're going to notice some soft tissue swelling, aka abscesses, which are going to determine treatment plan rather graphically. If you look at the lower jaw, the picture that's center at the bottom, you're going to notice that looking at the teeth on the chewing surface, you might not think that K and L would be bad enough to warrant extraction. But then when you look at the soft tissue, that gives you more information. If we go back to the x-ray, we're going to see that there's abscesses forming around those teeth. And so obviously the treatment plan is going to be affected by that. Okay, so in our order of operations, medical and dental history need to be collected. This patient happens to be a juvenile diabetic controlled with an insulin pump. He has a history of one broken arm. He's in the 40th percentile for height and weight. He has seasonal allergies that are controlled with over-the-counter medication. He takes a multivitamin most days. He sees a PCP, and he also sees an endocrine specialist. Just in case anybody doesn't know what PCP stands for, in this case it is primary care physician. The patient also sees a speech pathologist 2 times a week through the school. If you go back to the photographs, you're going to notice that this patient has a very deep bite. That can absolutely impact certain sounds and may require some speech intervention. And that is something that as an oral physician, we should be able to evaluate and make the referral. Okay, so we're going to look at dental history. As far as the dental history goes, they generally brush in the evening with a fluoridated toothpaste. They do not use floss or a rinse. They have not been to the dentist. This is the first time, age 7, for this patient to be at the dentist. And he is experiencing pain, which is interfering with his ability to eat, sleep, and concentrate at school. Children are notoriously poor historians, and parents don't always filter the history very effectively. So it's important to question the child about when the pain occurs, what kind of pain it is, and you have to give them the vocabulary to explain that. You may also find that some of your adult patients struggle with finding the vocabulary. So they may tell you it hurts all the time, but they may not be able to define that the pain is constant and throbbing, sharp and shooting, intermittent and under stimulus. But those are the kinds of questions that are going to help you narrow down what it is that you're looking for dentally. Okay, in this case, we're going to collect a social history. This patient is part of a blended family. He's the biologic child of the mother who did bring the patient today. He has an older half-sibling from the mother, 2 older half-siblings from the father, and 2 younger half-siblings from the blend. So this is a household that has 1, 2, 3, 4, 5, 6 children, as well as there's grandparents from the father living in the home, plus both father and mother are living in the home. He is currently in the 1st grade, where he has additional help with speech and reading. A 7-year-old in 1st grade does indicate that he either has a late in the year birthday and was held back by the school, or he has been previously held back. He's a friendly kid, but he has angry outbursts because of speech delay. This is not uncommon because he can't express himself verbally for him to react with a more emotional and or somewhat violent physical reaction because he's frustrated. He currently likes math, soccer, and Roblox. Okay, in this case, I did order a food log. What came back was that this child has a pretty balanced breakfast, but his snack in the mid-morning has a pretty high carbohydrate rate. His lunch has a Coca-Cola, which isn't really helping his teeth either. His afternoon snack is a cheese sandwich with cookie, again, high in carbohydrate, high in available sugar. He's your typical 7-year-old in that he does not particularly want to eat unprocessed food, so he's eating French fries and chicken nuggets, but they've made a nod towards vegetables with celery. He has a nighttime snack of chocolate milk and ice cream. Again, not our best choice for dental health. Mom wants us to know that he will not eat fish, most vegetables, soup, wheat bread, or bananas, and he must eat several small meals to maintain blood sugar. So a lot of information available and a lot of room for modified home care to help support his dental situation. And we are going to absolutely have to keep in mind that this is a big blended family with a lot of players. So the ability to have food modifications might need to apply to everybody in order to have efficacy. And we also need to be very conscious of the fact that as a juvenile diabetic, he needs to eat every couple of hours, and modify the pH level of his mouth through maybe gum chewing or toothbrushing might be really important to get him healthier. Okay, so he has severe pain in the lower left-hand side. That is his chief complaint. And he is able to express to us that he is very worried that they're going to rip the teeth out of my head hard. That's good information. We know why he's worried. Okay, so what we're going to do at this point, we've collected some generalized information. We've collected maybe some x-rays. We're going to go ahead and do an extraoral exam, an intraoral exam. We're going to take our measurements as they apply. We're going to make any pathology notes like the abscesses. We're going to diagnose tooth by tooth. We're going to treatment plan. We're going to present alternatives, and we are going to collect a CAT score for this patient. The extraoral is within normal limits and symmetric. His tonsils are Brodsky 2. His cranial nerve test was within normal limits, and oral cancer screening was clear. There were no reported heart problems, lung problems, or asthma. He has got seasonal allergies. This is the springtime, so maybe those are active. We need to know whether or not he's taking morning allergy medication. His diabetes is stable and controlled with an insulin pump. His intraoral shows the abscesses on the lower left side. He's crowded. He has flush terminal plane in his bite, which is usually going to end up being a class 2. He's 10% overbite and a 2 millimeter overjet. Okay. On his dental diagnosis, we find occlusal caries on permanent teeth. We find back-to-back caries on the upper right. We find in between the teeth decay on the anterior upper tooth. We find incipient decay on the upper right. Again, permanent tooth decay on number 14. K and L are showing us the abscesses. M has distal incisal lingual caries. The lower right-hand side has distal lingual incisal caries, a large cavity on the first molar lower right side, a smaller cavity on second molar lower right side, and buccal cavities on the permanent tooth on the lower right side. Okay, so when a child comes in at 8 years old with a history of somewhat violent outbursts, extensive caries, and significant anxiety, one of the options is a full mouth rehabilitation under general anesthesia. The advantage to that is that all the work is done at once and that the child has absolutely no memory of the appointment. You're basically giving them a fresh start with little or no discomfort or fear-inspiring activities. If we're opting for a full mouth rehab, we need consents from the endocrinologist and from the primary care physician that this patient is able and stable and can have that procedure done. Because of the number of times that he eats and because of the quality of his decay, I'm going to recommend glass ionomer sealants and glass ionomer fills on the permanent teeth in order to give them a better chance of remineralization and strengthening the teeth. In the case of the posterior primary teeth and the anterior primary teeth that have decay, I'm opting for composite fillings. I want to do a zirconia crown down on number S, and I want to do extractions of K and L. I'm opting for a zirconia crown because no plaque will stick to it. This might help to keep this tooth in his mouth longer. And then because I am taking out 2 teeth on the lower right-hand side, I cannot use a single-sided spacer. I need a dual-sided spacer, which is why I'm opting for a lower lingual holding arch. Okay, so For treatment planning sequencing and the special needs issues in this patient, I need to note that he's diabetic and I need to address that. He has high dental anxiety. His age and development is perhaps intellectually less than I might expect of a 7-year-old, and maybe I should be thinking in terms of him being more emotionally at the level of a 5-year-old. I need to get the necessary medical consent and collaboration from the two main physicians. I need to make sure that I'm compensating for the speech issues and communication issues that this patient may have, and I need to double check that I understand what the parents are looking for in this experience. Okay, so how are we going to follow up with this? We're going to put this child on a 3-month recare and a 6-month x-ray recare cycle until I see him go 18 months without a new cavity, in which case then I will ease off on the high return plan. I want to modify his home care and I want to incentivize him with like some kind of star chart. Maybe we could offer him a little extra time playing Roblox or a little extra time playing soccer outside if I get that home care. We need to modify the high carbohydrate and high available sugar content of his diet. This is going to help his overall diabetic condition as well as lower his chances of decay. I personally want to generate a report to the other medical members of his team so that they understand what my plan is for his oral health and also how I see that impacting his overall health. If I am a general dentist and I do not do GA, then I need a referral plan to a specialist and or I need to figure out an alternative that doesn't involve GA. And then I need to evaluate what tools are going to help this kid participate more in his overall health. So maybe what I'm opting for is a Roblox themed electric toothbrush. Maybe I'm upping the products that he's using to like Phosphor rinse or Elevate 5000 toothpaste to give him more available fluoride or some ACP to help for remineralization. I might opt, for example, to cement his LLHA with ortho cement, which has a blue color and is easy to see visually that it's still intact around the bands. But again, I want to go through and kind of make those choices as well. Okay, so again, I want to modify his home care to get him to brush 2 times a day for 2 minutes, to floss every day, to track this on a home calendar, and I want to up the amount of fluoride that's ambient in the mouth through Phosphor and Prevident. I want to modify the snacks to high protein alternatives. Some of those might be, instead of the Teddy Grahams and apple, I might opt for a cheese stick and apple. I might opt for hummus and celery as opposed to ranch dressing and celery. And I really want to limit the juice and the soda. I want to use sugar-free treats as much as possible and sugar-free chocolate mixes as much as possible. And I want to have him rinsing with water after eating or chewing xylitol gum after eating to restore the pH to a neutral level. Okay, so this is going to end our lecture for today. Next week's topics include the definition of disabilities, types and examples of disabilities, and creation of medical consent components. Please, over this week and a half, contact the members of your group and create the group chat for the project, send the link to me, and take a look at your readings. Thank you very much. I've enjoyed our time.